Good evening, everybody, and welcome to our ACAP webinar, Thriving in Transition from the Couch to the Clinic. This webinar is being provided by the American Council of Academic Physical Therapy's Student Leadership Development Committee. My name is Daniel Dale, and I'll be the moderator for this evening. Tonight, we welcome you to join a panel of students, clinical instructors, site coordinators of clinical education, and academic faculty as they discuss the ideas and share successes, and as we all have helped students thrive when moving from the virtual academic world into clinical practice and beyond. We'd like to thank ACAP for the support of the Student Leadership Development Committee. We'd also like to thank our liaison from the ACAP Leadership Oversight Committee, Dr. Nanette Hyland. And we'd also like to thank ACAP staff, Ms. Eleanor Trice and Mr. Jamil Tedlawi, for helping with the logistics of this webinar. As a reminder to all participants, this call is being recorded and the recording will be made available for viewing after the completion of this call. I'd like to introduce our panelists by name, and they will introduce themselves in just a minute as we get started tonight. Dr. Beth Quinn is the Director of Clinical Education at Bellarmine University. Dr. Kristin Luttrell is the Assistant Rehab Manager at Sam Swope Care Center Pillars Assisted Care Center in Masonic Homes in Kentucky. Mr. Trevor Taylor is a student physical therapist at the University of Kentucky. Dr. Andrea Maynard is the Supervisor of Rehab Services at St. Joseph Hospital, Maine in Lexington, Kentucky. And unfortunately, Ms. Lauren Petterson could not be on the call tonight, but she is a student physical therapist from the University of Central Arkansas. We also on the call have our ACAP Student Leadership Development team. Many of our team members are on the call serving as moderators for tonight. Ms. Carly Esposito, student physical therapist from Mercer University. Dr. Carrie Hawkins, Program Chair at Whitworth University. Dr. Darren Jaffe, recently graduated from Temple University. Ms. Lauren Petterson, again, from the University of Central Arkansas. Ms. Kara Schildmeyer, student physical therapist at the University of Cincinnati. And Dr. Kenny Wessel, Doctor of Physical Therapy at Charlotte One-on-One Physical Therapy. Our objectives tonight can be found on the screen. Tonight, we're hoping to engage each of you in a discussion on the successes and the obstacles that we face in our individual roles in making sure that our students are successful as they transition from the virtual learning environment to the clinic. We recognize the unique challenges we've all faced this year related to the COVID-19 pandemic and intend to address what we believe have been successful practices and unique insights from our panelists. Our session's intended to allow for open discussion and sharing of ideas in whatever way you feel comfortable contributing. For the first half of our session, our panelists will answer pre-written questions that address the objectives. They'll also respond to questions that are sent in by our registrants, and we'll respond to those that are sent in via the chat as well. The second portion of our webinar tonight will be conducted in breakout rooms. We will break you out into one of two rooms, one room consisting of students and clinical instructors, and the other room consisting of faculty and site coordinators of clinical education. We'll be talking individually in those rooms and really have a chance to break out and have a good discussion about successes and obstacles that we've all encountered. In preparation for that assignment in the second half of our session, I'd ask that if all participants could rename themselves at this time by adding the following after your name: an S if you are a student, a CI if you're a clinical instructor, an SCCE if you're a site coordinator, and an F if you're faculty or a director of clinical education. The call will be ending from the breakout rooms at the end, so there will be no need to return to the main room once we've finished, but we'll remind you of that when we get there. We also encourage all attendees to watch our Thrive video series, in which our panelists recorded videos discussing about ways that they've thrived throughout this pandemic. Those will be available on the ACAP YouTube page later today. Also, before we begin, we'd like to make all attendees aware of all of the excellent resources from ACAP here on the slide. Resources here are available for students, clinical instructors, and clinical education, as well as the ACAP Leadership Compass and guidelines that ACAP has provided for programs for returning to classroom and lab activities. Now, with all of that information out of the way, let's get started with our first panel question. And again, after we introduce the first question for our panel, our panelists will be introducing themselves as well and telling you a little bit about themselves. So our first question for our panelists is, from your perspective, what has been different related to clinical education this year? And we'll open it up to our panelists and ask that they again introduce themselves as they answer. And I think I'll kick it first to our panelists, to Dr. Beth Quinn.
Hi, good evening. My name is Beth Quinn. I'm the Director of Clinical Education at Bellarmine University in Louisville, Kentucky. And it's an incredibly loaded question because there have been so many things that have been different on the classroom component, with our students having to learn the curriculum and learn skills in a very atypical manner. A lot of times with remote learning or labs that were separated from didactic curriculum. So it's certainly been a different consumption of the material to begin with. And then the clinical education piece, we've had altered timeframes and carryover to when students start. So it's certainly been a much different time. One of the things that we hope with the transition this year is to really emphasize the importance of clinical education. These students might have had limited lab time this year due to pandemic, and that makes this hands-on experiences of clinical education all that more important for our students. And as we're preparing some of our students to start their first clerkship, their first integrated clinical education experience, we're really emphasizing with them how important this transition is and how important the in-person hands-on component of it is going to be for their curriculum at this time.
Thank you, Dr. Quinn. I'll ask Dr. Andrea Maynard to contribute next from the perspective of a clinical instructor. What's different this year, Dr. Maynard?
Hi, my name is Andrea Maynard. I'm a clinical instructor at St. Joseph Hospital in Lexington, Kentucky, Maine. I'm also the supervisor of rehab services there. And we've had a lot of dates have to be changed and shifted due to COVID, rotations be condensed. And we also have a lot of COVID patients at our facility, and our facility does not allow patients to go in these COVID rooms. So we have to rearrange some scheduling and have other therapists help us with some caseloads. But also we have multiple students coming in at multiple times, leaving at different times, and just having to adjust to someone starting, someone leaving, two people being with me, someone else being with someone else at the beginning, and just letting the students know that they need to be open and honest with who they're with and where they are in their learning and what they need so that we can better help them along their journey.
Absolutely. Thank you, Dr. Maynard. Dr. Kristin Luttrell, from a site coordinator of clinical education, what's been different for you this year?
Hi, I'm Kristin Luttrell. Can you see me? And I am a clinical instructor as well as a site coordinator for Masonic Home of Kentucky in Louisville, Kentucky. It's a skilled nursing facility. I've been there since 2009. This year is definitely different. Skilled nursing facilities for sure have been through a lot of changes over the last year. Our communication with directors of clinical education, the level of communication obviously has increased, as well as the topics have changed from our policies and procedures of how we are managing COVID patients that are in our facility or testing positive in our facility, to how students are interacting with our patients from a short-term rehab standpoint, from a long-term care standpoint, and then how it transitions with if we have a positive COVID patient and whether or not that student was treating them or not. So obviously our goal is not to have them treat positive patients, but we never know when they're going to test positive. So the communication from the site coordinator, myself, to the director of clinical education has been challenging in regards to the amount. But at the same time, we go back to what the goal is for this transition, and it's patient care and teaching our students to interact with our patients no matter what the diagnosis is, and making the most of that clinical education that they can while in person.
Thank you. And before we go any further, I think for all of us as faculty and students on the call, I want to express my thanks both to you, Dr. Maynard, Dr. Luttrell, and how you've managed the pandemic and offering these opportunities to our students. I know as an assistant director of clinical education and with Dr. Quinn as a director of clinical education, our jobs are made so much easier by the opportunities you provide. So continued thanks, especially throughout what has been a very challenging year. So thank you. All right, Mr. Trevor Taylor, I'd like to reach out to you and find out from a student's perspective, what's different this year related to your clinical education?
Hi, my name is Trevor Taylor. I'm a second-year PT student at the University of Kentucky, and I'm right now in the middle of my first full-time clinical. And what worried me before going in was the lack of hands-on experience. Being all that distance learning, we had only a few days to actually learn the things and limited days to practice with our classmates and have our professors also overseeing us. So anxiety ran really high, trying to make sure that when I'm working with my CI, I wasn't embarrassing myself, but more importantly, that I wasn't putting the patient in danger. So that's one of the first things that I mentioned to my CI and tried to get that handled and to make sure that we're all on the same page to move forward.
Thank you all very much. So from this question, I want to branch off a little bit deeper and we'll kind of see who wants to pick this one up first. But if we're talking about what's different related to clinical education, if you had to share something with one of the other groups on this call, so if we said, well, we'll start with Trevor, with you as a student, if you wanted to share something with clinical instructors that were on the call, what's that one take-home point that you'd want them to know about students that are coming into the clinical environment now that's helped you?
Well, most of us, we're going to come in trying to be as confident as possible, even though we are a little shaky about some of our skills. So getting that open line of communication to say, I know you might have not had as much experience on some things, and try to encourage the students to be forthcoming to say, hey, I am really good at this, but I do need help on this. If you open those lines of communication, instead of having the student worried and try to hide them and actually create more harm, it would be so much easier for our comfort level and for our ability to learn, because you'll know exactly what we're missing if we're not scared to say it. So just presenting yourself to be open and willing to understand that we might not be perfect yet. And it's good to be reminded about that.
Thank you, Trevor. Dr. Maynard, from a clinical instructor perspective, what are some things that you'd want students to know as they come into your environment in the
I want them to know that I don't expect them to know everything, especially in my setting. I work in an acute care setting, so it's not a major focus in school anyways. And I send home packets for them to review things, lines, tubes, diagnoses they may see, to kind of give them a heads up of these are some hot points I want you to look at. But just to be open and honest, and where you are in your learning, let me know what you know, but I'm also here to guide you and teach you along your acute care journey.
Thank you. Dr. Luttrell, similar question to you in regards to both your role as a site coordinator and as a clinical instructor. What do you want academic faculty to know about what's different from your role, and how can academic faculty help support you?
Absolutely. So from an academic standpoint, the biggest thing is just support, being available to have that open line of communication. We are going to have days that go as planned, and then we're going to not have days that go so well. So being able to have that line of communication that's easy to access, as well as having a backup plan if things happen. Being in the clinics since the pandemic started has been a challenge in regards to the fact that sometimes you just don't know how it's going to go each day. We have come a long way over the last year, and we're definitely in a better spot than we've been over that year. But at the same time, being able to reach out to that academic site and say, hey, you know, we might need to look at changing the times, or we might need to look at changing the hours that the student might be in the clinic because we don't have a caseload that can manage that student. And having backup plans and options available has helped out tremendously. From a CI standpoint, I totally agree. It comes down to communication, being open to having the discussions early on about what you do know versus you don't know. We don't expect you to know everything. And our job as a CI is to engage you, as well as emphasize the things you do know, as well as provide education on the things you may not know and practice. We are here for the patient, but at the same time, you allow us to be better clinicians because we can teach you what we know.
That's such an outstanding message. Thank you so much for that. Dr. Quinn, I'm going to put you on the spot here. So you're in front of your students every day. If you had a private moment to share with them kind of some parting words as they head off to clinic, what would you want them to know in relation to clinical education as they head off to their clinical sites?
Sure. Okay, little twist on the question. But one thing I actually wanted to tag on to what Trevor said. With some of my students, it was in the classroom today, but we were reviewing a resource on the APTA's website on 8 ways to make the most of your clinical experiences. And one of the phrases that resonated with one of our students was to look to improve yourself, not prove yourself. And I think that piece is fantastic to think about. You know, obviously at the end of the day, our students need to get to a certain performance level, but it's not necessarily about just going out to prove yourself. It's every day. How can I get better? How can I make my skill sets better, my communication better? So it's all about improving yourself. And from my parting words of wisdom to my students is to always think about all of the other things going on. It's very easy for us to think about how hard our certain path has been. This past year has been hard for everybody in their own given role and responsibility. And while there's a lot to dwell on sometimes, I want my students to also recognize that it's been hard on our clinical facilities. It's been hard on our clinical instructors. It's been hard on faculty. And if we can all really continue to appreciate the challenges and also recognize how much we've overcome over the past year, I think it goes a long ways in helping to build some grace and kindness with each other, because we all need an abundance of patience and kindness. And so just helping them to recognize that everyone's had their trials and tribulations this past year, and it helps you become a little more forgiving when you do have to flex your caseload or change your schedule or treat somebody you weren't expecting to see. It helps give a little kindness and patience with that.
Absolutely. Thank you, Dr. Quinn. Thanks for entertaining the twist on the question. I knew my panelists are quite flexible and excellent at what they do. I think that speaks to so much of what's going on, and you speak to that big topic of resiliency. And we've seen, you know, multiple ACAP webinars that have come out of this group and other things. But when we talk about resiliency, I think we all have to give ourselves credit that we've been outstandingly resilient over this past year as we've managed some of these trials. So fantastic. I see that people are contributing in the chat. Thank you guys for your thoughts there. Continue to put questions in there as well, and we'll be able to answer some of those. So our second question for our panelists is, what have you found to be helpful in keeping students engaged and attentive? And I think with this one, we're going to kick it off with Mr. Trevor Taylor and ask directly at the source. So Trevor, as a student, what has kept you engaged, or what has helped to keep you engaged and attentive in the virtual learning environment as you prepare for clinic?
Well, for me, I'm kind of drawn to the professors that are energized, that are excited to be there. We all know that it's not great to be alone and by yourself in a room trying to learn. And they can address it at the beginning, but then after that, they're so excited to see us. That professor is like, I'm glad to see everyone's face. Turn on your cameras. Instead of making you feel like I'm going to make sure you're here, it's more like, I'm excited to see you. And that makes me excited to see them too. So that in itself just makes me want to engage. Again, some professors that show videos of previous ones, it makes you feel detached. So I like professors that are actually there in real time with me, instead of doing a video and just say, watch this when you want to. But when I feel like they're giving as much effort as I'm giving, it makes me want to give more. And there's a couple professors that at the end of class, they kind of make it more open to say, so what's really going on with you? Tell me how you actually feel. And open that communication after class, you'll actually learn more about how we really feel, instead of us answering questions, trying to prove ourselves again. But it helps us to say, everyone's real. It's a more real life experience that we can actually explain our problems to them and they can relate to us. And that really helps out and makes me want to contribute more.
Outstanding. Thank you, Mr. Taylor. Let's go to Dr. Luttrell and ask the same question. As students are coming into your facility, how have you found keeping them engaged and attentive when they've gotten to the facility? Or have you witnessed any problems?
First of all, I'll be completely honest. They're coming in more energized than some of our staff have been over the last year. We've obviously had our challenges, and I actually have 2 University of Kentucky students with me right now. And they've come in so pepped to learn and excited and energized, and it's actually been absorbed through our staff. And I've got residents and patients, whether it be long-term, that they're just in the gym and they get to see just the energy that they're coming out with. So I go back to, they're providing more energy in my clinic by being there. So it's not been how I've helped keep them engaged. It's more of them bringing back what clinical education is all about, and the desire to learn and the desire to teach. So I applaud them for what I've had. What I would tell anybody that I feel like I do need to engage is just having that open line of communication where we both get to decide, what do we want to learn today, making it interactive, trying to have that communication in the beginning where, what are we going to challenge ourselves today with? What can we learn?
Outstanding. And that's so awesome to hear that our students are bringing that energy to clinic and helping lift the spirits of everyone. Dr. Maynard, same question to you from a clinical instructor perspective. What have you found to be helpful in keeping students engaged and attentive?
I keep the students engaged by throwing them in early. I don't let a lot of observation go on and let them kind of sink into the background. They may stumble on a couple of things on evaluation questions, or they may ask something in the room, which is totally appropriate as we're working, but just having them start getting their hands on the patients instead of waiting until week 2 to start this, until they're comfortable with the documentation system, just letting them find their way and letting them get involved right away.
Excellent, thank you. And Dr. Quinn, I'm going to ask you the same question, and then we'll get to the chat. I see the chat is opening up here. So Dr. Quinn, in regards to kind of your teaching strategies, faculty, what have you found has been helpful in keeping students engaged and attentive?
Sure. So one of the courses I teach is cardiopulmonary physical therapy. And for once, I had an advantage with COVID in that suddenly the cardiopulmonary system was relevant to our PT field. So we were certainly able to try and incorporate as much real-time application of the news and news articles and research that's hot off the press this past fall semester, because those were super relevant topics to all students. So that has helped me personally with that course. And in the classrooms, we certainly try and keep as much case studies and patient-based problem-solving approaches in reassuring students that you are going to get to treat patients very soon. That's why you're here. So continuing to connect the original interest in the profession to help motivate them to really try and stay engaged. It was very hard having students on a small square on your screen and trying to keep them engaged, especially after some really long days of a lot of didactic curriculum. I do think some of the pandemic teaching helped faculty members focus on what is really important, because sometimes there's some fluff in the curriculum that may be unnecessary, and we could really focus on what is critical to the learning objectives. What can we really help students focus on? Which, more is not always better. Sometimes it's best to condense it to highlight what things really need to be focused on. For our class that's about to go out on their clerkship this summer, we do have a readiness skills checklist lab that they're going to be doing in a couple of weeks. And when we were talking about it this afternoon, I think the students were actually really excited to say, oh, wait, I do want to practice these things before I go out and perform these skills on patients. So it's trying to fuel that excitement to help conquer the nerves, because right now they're battling I'm getting nervous about this upcoming rotation. So we're like, okay, feed that nervous energy with productive practice and developing the skills and refreshing those skills. So we're just trying to harness that nervous energy with productive energy.
That's great. And I think you bring up such a good point that, typically there is that nervous energy, that excited energy from our students as they get ready to go out to clinic and as they get to our clinical instructors, our site coordinators, and to our clinical sites. And I don't know about y'all, but it's enhanced this year. Our students are even more anxious as they deal with, am I going to encounter or treat a patient who has tested positive for COVID-19? Do I know all the rules to keep myself safe? Am I good with my PPE? There's so many facets that have just ramped up for our students. And so I think that kind of moment of harnessing that anxiety into positive energy has been really neat to see as we've gotten our students ready. So fantastic points from our panelists. I want to take a second to recognize in the chat. I saw a couple of different comments. Chase, thank you for commenting on, I'm not sure it is an unpopular opinion in your chat about loving when professors engage students randomly. It may be unpopular amongst other students. I think faculty love it. But I think it's a great point. And I think somebody later in the chat, it may have been Carrie, said, I think if that perspective is set from the beginning, that students know how the faculty are going to operate the courses, then you can respond. But it's all about creating that positive environment. Is in an environment where it's okay to be wrong and it's a learning experience for everybody, even if you're, kind of called upon to do that. And then I saw some good positive energy coming from Heather as she was talking about, responding to the challenge of COVID and being excited about jumping into clinical assignments. So Heather, we're excited for you as well. So it looks like everything is moving along well. So very nice. Keep putting your questions into the chat. We'll have a little bit of time to address those, but we'll move on to our panelists to kind of our third question here. And this is, I kind of asked you a little earlier, maybe some specific questions, but we're going to ask each of you, what advice do you have for all the parties that are on this call, our students, our clinical instructors, our site coordinators, and our faculty in preparing for and managing the clinical environment? And I think what's interesting about this question is we do have to put into perspective, and I recognize that our four speakers on our panel tonight are from Kentucky, and recognizing geographically that we're all under a lot of different restrictions and return to kind of clinical education, return to some of our academic teaching styles, and it's a wide gamut of where everybody's at right now. But as I've talked to our panelists, Kentucky is moving a little bit quicker. And so they've had students back, they've returned to some of their academic stuff. And so I thought you guys could provide some advice for maybe those faculty, those clinical sites that haven't returned to full student participation yet. What advice do you have in preparing for and managing that clinical environment? And let's start, we'll kick off this one with Dr. Maynard.
I think for the students, just reaching out to the CI or the site coordinator, asking questions about the site, what their expectations are, what who they're expecting to see patient-wise, what to review beforehand. Do they need to bring certain PPE? We provide all the PPE for the students coming into us, but every place may not be that way. Asking about COVID patients, and if I encounter a COVID patient, or if I'm in a COVID, or I see a patient and they test positive later for COVID, but I was in that room, what are the steps? Just kind of maybe forward thinking about these things that may happen. We hope they do not happen, but preparing yourself, so take down a little bit of the anxiety that occurs, to know that we have a plan in place that if X, Y, and Z happens, to protect you or to take the proper steps for that.
Thank you, Dr. Maynard. Let's jump to Dr. Quinn.
All right. So I already mentioned a little bit on the, have kindness and patience. I think we all need to continue to keep that at the forefront of our goals to aspire to, because we all can use some kindness. For our students, and really even our clinical instructors, but certainly my students, I've really challenged them to set their attitude, to figure out, how do they want to reflect on the challenges of this past year? How do they want to go forth into the clinic? Do they want to complain about how hard it was online, or do they want to flip that to, okay, online was challenging, so now I really want to make the most of my hands-on component of the program? How are you going to set that attitude going forward? Because So much of this past year has been out of our control, out of anybody's control. And so really the most you can do is focus on how you want to respond to it and how you want to embrace the opportunities going forward. For faculty and really even SCCEs and clinical instructors, the other piece is to continue to encourage collaboration and information sharing. Here in Kentucky, we are part of a consortium with the PT programs in Kentucky and Ohio. And the DCEs at those schools have been such a vital resource for me in helping to figure out what our COVID policies are and how do we support students reentering and when do we quarantine them. And, so collaborating with other universities, with our clinical partners, even with other health professions on my campus has been incredibly important because it is evolving constantly. Where we are today may look very different than where we are a month or two from now. We're actually going to be transitioning, at some point to not wearing, not having mask mandates. How does that apply to clinical settings? How does that apply to break rooms with your CI? So they're just all continuing to build all these questions that we don't know the answers to yet. So continuing to collaborate with our clinical partners, with our other programs will really help try and answer those problems. And I think the more answers you have, or at least some type of plan in place, the lower your anxiety for your CIs and for your students can be. So just really focus on that collaboration.
Excellent. Thank you, Dr. Quinn. Mr. Taylor, what advice do you have?
Well, I'm going to brag on my CI, Dr. Maynard, a little bit. But for me, I thought my orientation, even before getting to the clinic, I knew exactly what I was supposed to do the first day. I had a detailed map of where I was supposed to go, what the door looked like, who to talk to when I first got there. I felt 20 times better before even walking in the door. But what I want to really talk about is other students. There were 4 other students that were at the clinic at the time, and they took the time to tell me how the experience was, of what they were being challenged with and prepare me. So if you're at a clinic and you have new students coming in, step up. Tell them to say, hey, you need to worry about this, or don't forget about this. Those little hints, it gave me confidence, and it stopped me from making silly mistakes from the get-go. So my confidence, by the first week, I felt like I was ready to do almost anything just because the other students helped me out. And Andrea, Dr. Maynard, she was encouraging me to express how I feel and to keep on pushing forward. So that was the best part for me.
Outstanding. It sounds like you've had a great orientation and start. And I think we've heard from all of our panelists again, talking about the importance of communication, all of the upfront communication, stressing, to the students, communicate what's on your mind, what's making you anxious, what's bothering you, what do you need to know more of? And then from the CI perspective, communicating, the things you've dealt with. I think for some of us in the clinical settings, there's so much burnout and stress that's happened over the last year that you forget maybe to communicate that to the students. Let them know what your experience has been so that they can share in really what their role as a healthcare professional is going to be. Sharing those experiences that you've gone through is so helpful to our students. So outstanding. Dr. Luttrell, what advice do you have?
Well, I'll be honest, coming after all 3 of those, it makes my conversation piece a little bit harder. So they've given me a little bit of a challenge. But to reiterate what Dr. Quinn said and Dr. Maynard, I agree. Everything that they've said is accurate. The biggest thing from my standpoint as a side coordinator is I'm also a CI, so I'd come down to why I chose to be a physical therapist. I look back to why I chose to be a CI as well as a site coordinator. I believe it makes you a better physical therapist. It allows for that patient-centered care that we all strive for. So the advice that I could give to all parties, it comes down to, communication, knowing how to energize your student if they need it, or vice versa, having them energize the CI and the clinic again, for everything that we've been through over the last year. Knowing how to show your value as a student, showing your value as a site coordinator, coming down to, whether it be you're the point of contact for all communication between the student and the CI in the beginning, or the director of clinical education in the beginning. Knowing how you can change or make for the better that transition into the clinic, and engaging any kind of entity, whether it be the director of education, the CI, or even the student party. All of them matter, and this is what makes it all about education and learning, so we can be the best that we can be.
Outstanding. Thank you all. All right. I think we've got time for about one more question. And so this one is actually a little bit of a surprise. The panelists, this is one of our written questions. So we'll move on to the next one. We might catch them a little off guard, but I think they'll be able to jump right into this. So one of the concerns, I think, from an academic faculty side that we've had is recognizing we've lost a lot of our in-person time where we would normally be working on communication skills and professionalism. We haven't been able to bring in some of our patients that usually would come into the academic program and the students would have a chance to interact. Perhaps we haven't had a chance to do as much hands-on service learning or service or clinical experiences because the pandemic has limited some of those opportunities. And so as faculty, I think there's a concern of, are we providing the opportunities to promote the communication skills necessary in our profession? So the question is really, how can we best promote communication skills as our students transition to this in-person patient management following the virtual learning environment? So I think I'll start with our clinicians. So I'll go back, since Dr. Luttrell just answered, I'll go to Dr. Maynard and see if she has any ideas in relation to promoting communication skills as students transition into the clinic.
I think it goes back to, you're here in the clinic to practice. So we had a situation come up recently where I needed Trevor to call a doctor. And I said, here's what to expect. Here's the number you call. And I gave him the high points of what I wanted him to say in a concise manner. He quickly repeated back to me what he was going to do. And then he made a phone call with me standing there. And no, it didn't go as smoothly as your first phone call to a physician probably would as a student, but the doctor was very nice to him. And we then talked and said, well, this is what I would have said. And this part I would have said second versus this. I would have started with this and then went here. And it just gave him a chance to kind of work out all the kinks and then say, okay, next time I know I'm going to phrase it this way, or I'm going to start with this and then go into this. But you don't, until you do it, there's going to be some errors. So just getting them to practice and getting them to get involved and do it. We start talking with the nurses very early on. They have to communicate with the nurse before seeing the patient. And what do you ask the nurse? What did you find in the chart that you think is relevant to ask the nurse? And again, I just talk with them before they make that conversation, and then have them repeat back to me and practice on me, and then go on and ask the nurse. And then as the rotation goes on, their communication skills improve because they've had several opportunities to go talk to several different people from throughout the hospital. But just being able to give them guidance and feedback after the conversation happened helps strengthen them for the next time they have to make that move.
Excellent. We'll throw the same question to you, Dr. Luttrell. And also, I saw in the chat a mention of, how much leeway is okay. And I'll even give the caveat, is leeway okay? Are we going to treat it any differently this year? So we'll pose that same question to you, Dr. Luttrell.
Absolutely. So I think it comes down to communication between your CI and the students in the very beginning. Everybody's learning experiences are different. You may have students that are very much want to be thrown into the midst of patient care immediately. And then you have those that are a little bit more reserved. And I think you'll see a little bit more reservation to those interactions early on with the recent transition from virtual learning to in-person learning. So I think understanding those students early on and being able to have that communication between your student and CI relationship to help mold your student into what you want them to become at the end of their clinical rotation. knowing that you want them to succeed as much as they want to succeed, and being able to determine where they need more practice or where they need more guidance. I've had many students that enjoy listening to me give patient education for the first time, and then they start feeling more confident as their time in the clinic improves over their 12-week rotation, 9-week rotation, whatever it may be. Some students do really well on family dynamics, and then some students do really well on their first phone call to a physician because they don't have to make that eye contact. So knowing how patients and students can interact with each other just takes time between that relationship. The leeway question, give me a little bit of guidance. What are you looking for leeway wise?
So in reading the chat, the question was how much leeway would be reasonable in regards to kind of that difference this year with communication skills versus maybe a year in the past, where we would consider a traditional academic schedule has gotten them to clinic.
Absolutely. I think leeway is a hard term to say you need 2 days extra here or a week extra here. There are no way to say all students are the same. That's the best part of that relationship with a CI and a student. You determine together what is considered necessary and appropriate to make sure that they succeed in the clinic. So again, it goes back to that just communication between the team, knowing how to push your student as well as how to guide them at the same time. So I think it's just, there's no perfect answer to that one, unfortunately.
And I see Dr. Hayes had some follow-up there in regards to maybe students saying, I haven't had that much interaction with people, especially when it's things like a safety or professionalism flag. I think from my perspective, and again, I'm an assistant director of clinical education now, but I still work in the clinic. My expectation for my students is that they still are up to par as they would any other year. And really it's up to the DCE and ADCE to help meet those concerns. If there are students who are a little bit behind, whether it's due to the pandemic or not, if it's communication, then it's really working with the clinical education team, the site coordinator and the CI to figure out how to get them up to speed as fast as possible. But I think, with our students, I guess my thing is just because you haven't had as many opportunities with live patients doesn't mean that the clinical gets kind of a bypass of, well, it can be worse than usual. We're still expecting that same entry level perspective there from my end. Dr. Quinn, Dr. Maynard, go ahead.
I agree completely with Kristin that, you may not have had that much interaction. You may have been on Zoom. You may have been kind of isolated, but this is your chance to practice. This is your chance to do scenarios off of your CI, or if there's a tech in the facility, a lot of times we have some of our techs that have been with us for 15 and 20 years, and they've worked with students and helped them with transfers, or helped them even with communication or phrasing, and just grabbing those extra people that you see in the clinic that you feel comfortable interacting with and asking them, hey, can you help me with this, or hey, can we review that? But your clinic rotation is just your time to get in and do it. And I usually never accept I haven't had that yet, or because especially when we're taking second years in the acute care setting, there's a lot of classes that they haven't covered yet when they come out to us. And that doesn't mean that you're not going to do wound care with me because you haven't had a wound care class. So here's the stuff that you're going to review tonight, and then we're going to get hands-on tomorrow with it.
Excellent point. Dr. Quinn, I'm going to let you jump in from a DCE side, and then we're going to let Mr. Taylor have the last word. So Dr. Quinn first.
Sure, I agree. I think, at the end of the day, we're not compromising our objectives and learning expectations for our students. We recognize that they may need a little bit longer or a little bit easier transition into the clinical site. I know Andrea throws her students in pretty early, which is fantastic. And I think that can be so effective. Some students may have a little more apprehension or nervousness at the beginning, but by the end of the rotation, the expectations are still the same. And so it's just a matter of mapping out that way to get there. We've had some CIs be incredibly creative this past year in either filling gaps of time when caseload was really slow at the beginning of the pandemic. They did a lot of creative things to help simulate learning environments. We've also likewise come up with some new assignments for students to help facilitate the learning and meeting some of those objectives this past year too. So the leeway at the end of the day is not there. Same learning objectives. It just may look a little different on the journey there.
Outstanding. Mr. Taylor, we'll kick it to you for final thoughts on this question, and then we'll wrap to go to our breakout rooms.
Well, what really helped to me at the beginning is I actually got to round for like half a day with a different PT, and I got to see their communication style and got to realize that everyone kind of approaches each patient a little bit differently. And I could kind of pick and choose what I liked from these different PTs and kind of formulate my own style. So having that different perspective from seeing different people talk to patients helped me find out my own style. But to echo what Andrea said earlier, I'm only there for 9 weeks. The sooner I get to get comfortable talking to people, the better it was for me. It wasn't great at the beginning. It was a little bit difficult. But I think as students, we know it's going to be difficult, and we might be hesitant because we're scared. And being a little nudge, maybe not do every day. We're not going to be the lead right away, but slowly becoming the lead person and feeling like you're becoming the lead, that really helped me work with my communication skills and to trust myself and to start talking to people in a more professional manner and start getting compliments back from CIs and from patients.
Outstanding. I want to thank all of our panelists for their contributions tonight on how they've thrived in transition and helping our students continue to thrive in the clinical environment. So the next portion will be entering our breakout rooms, and we really want this to be a true discussion. As a reminder, you'll be assigned breakout rooms based on students and clinical instructors in one room and faculty and site coordinators in another, but you also will have the option of jumping back to the main room and asking to go into the other room so you can hear the perspectives from those groups. But we're really looking to hear from you as participants in the call and sharing ideas and discussions about how we can continue to help students thrive from our own individual roles. As a reminder, the call will end from the breakout room, and breakout rooms will be recorded and available to viewers. I want to thank everyone for their participation, and we look forward to seeing you on the next ACAP webinar. And at this time, we'll go ahead and open the breakout rooms.
Hey, everybody. So it looks like we actually have a pretty good mix of students and CIs. And so Dr. Maynard and Trevor, to kind of start us off and to break the ice, I'm going to ask you guys a couple of questions. And then from there on, Kara and Darren and Carly are going to be monitoring the chat. So if you guys have questions, either unmute yourself, put it in the chat. And yeah, like Dan said, we're going to want to just good discussion and we'll go from there. So first off, Trevor, you just spoke. So Dr. Maynard, what challenges have you specifically encountered in helping students transition to the clinic? And was it expected? Was it unexpected? And kind of elaborate off of that.
Personally, we've had some challenges with professionalism, things such as not arriving on time or thinking that just because we finished a little early, then we're out early that day. There's not other things to work on or to review, and just reminding the students that we need to help the other therapists. There are still patients that need to be seen, reminding them of traffic and how the mornings work because you're not out driving in it, which to me, it seemed obvious because I had been driving it through all the pandemic, but I have to kind of take a step back and realize that some people have been quarantining at home and haven't been out and haven't been leaving, and just reviewing that with the students that, you know, came right away, right in 2020, as we were still in the midst of a lot of this. And then just being forward with those students now. So I set those expectations up front. So there's no confusion or further issues with any of that. But everybody seems to have adapted really well once they realize, you know, oops, we do need to do X, Y, and Z, or I do need to correct this. There really hasn't been any pushback.
Very nice. And Trevor, we'll throw it to you. So what challenges did you expect to face going into clinic? And then what challenges did you actually face? And if you did any?
Well, I said earlier, I was worried about the hands-on lack of experience, but for me, that really wasn't that much of an issue. I was tapped into my strength, and that's what I encourage everyone else to do. Like for me, I like talking and interacting with patients, and actually playing to my strengths made me more comfortable and gave me time to kind of earn everyone else's approval that I am competent, that I can do things, and it made it easier to admit the things that I can't do. So by doing that and taking that mentality, playing your strengths up and admitting your weaknesses, you can really maximize your time. Because I spent a lot of time with Andrea reviewing things that I wasn't comfortable with. And now some of my weaknesses are now my strength. I like the hands-on stuff. I feel so much better with stuff like that. So that open communication from the get-go, it solved a lot of my problems because I had a pretty good bluff. I wanted to say, I'm really good at everything, but I wasn't. And she said, don't do that, Trevor. Tell me what you need to work on and we'll work on it. And it made it me comfortable, and it made me a better experience to learn a lot more.
Awesome. So we'll throw it to you guys. We want this to be a discussion. So if you have a question, either unmute yourself, and I see Carly posted in the chat.
Yeah, I can ask it out loud, but how would you suggest that a student who maybe is more confident than in their skills than what their CI is allowing them to do, how would you suggest that they advocate for him or herself in a scenario where they feel as though they could do more than what they're being allowed to do?
I would say I sometimes am not as good with giving positive feedback. I will tell you what needs improved upon in the room, but I don't say what went well in the room, which is something I do work on. But the student then may be speaking up and saying, I think this went really well. I think I completed this evaluation completely. I'm ready to do the next evaluation on my own or just with you supervising. I don't need any cues or assistance. Them being more open and honest that they feel comfortable with that next step, and then me taking a step back and just watching, and if everything performs very well, then giving them the chance to do the next one.
And I also like sneaking in, kind of saying, hey, I want to try this real quickly. I think I'm pretty good at it. I want to see what you think. And then you're kind of showing off at the same time, but saying subtly, I can do this. Let me take the lead next time. And from other clinicals that I've went to, like my integrated clinical, it made a big difference once I pretended that I could do it. And they thought that, yep, okay, maybe he's a little bit better than I thought he was.
Carly, I think that you'll find that kind of speaking up for yourself and kind of giving that initial ask is a lot of what will get that ball rolling, right? I know it can be kind of intimidating the first time, but it's one of those situations where, and we kind of touched on it earlier, some of the panelists were talking about just being okay with embracing that uncomfortableness. You know, that's where at least I feel like I learn the most, is by just kind of jumping into something and making mistakes and then learning from there. And I think like a lot of people have said too, is just setting those expectations up front where, you know, your CI needs to know if you're the kind of person who wants to be told to do things at certain times, or wants to be that person that kind of would rather ask once you feel comfortable. So I think setting yourself up for that at the very beginning will probably go a long way.
I also think part of that comes down to like our critical thinking skills in terms of that. So why are you advocating for something? Maybe it's an intervention, maybe you know, you want to try to implement something new, and showing your critical thinking side in terms of, I want to do this because X, Y, and Z to a CI, I think really goes a long way to show, even if you're wrong, you could still kind of show them, advocate for that. And then if you're wrong, your CI will still let you know, and you can kind of talk about it after.
And I think like a good way to do that off the bat. It's just like iterating that in an email to your CI before you even meet them, or maybe if you go shadow your first day, kind of talking about your learning style, because that can set you up for maybe taking on more at first if you're more comfortable with that, or letting your CI know that maybe you're not ready to jump into things right away if you already know that's your learning style.
Has anyone been, and this is, I guess, a question based on the most recent clinical experience that I was assigned to, they kind of sent me all of these different surveys to fill out based on like my leadership style or my student style, and how I handle new situations and things like that. Are you all finding that clinical sites are asking those things before you even arrive on the first day?
Some schools have like a learning inventory and have like surveys like you're talking about. How best do you learn? Is it and give different scenarios and stuff that I love to review, because it kind of gives me a deeper insight into you. And we've got to get to know each other fairly quickly, because some students are only here for 9 weeks, and others are here longer depending on where they are in their rotation. But we email back and forth several times before the rotation even begins, and I just constantly am asking, do you have any other questions? Do you have any concerns? Even like the week of moving into the rotation, I drop my cell phone number and I say, if I'm not responding via email, please text me if something comes up, or just let me know and we'll work it out.
Yeah, in my clinical rotation right now, I was asked before I got there to do a DISC profile. So I don't know if anyone's had to do those, but it's basically a communication style based off of your like inner motivators. It's almost a personality test, but more geared towards communication and leadership styles. And it's actually a really good one if you are a CI and you want to send to a student. It's really great to see. So there are 4 types. D is dominance, I is influence, S is steadiness, and C is conscientiousness, I think are the 4. But it kind of just shows what guides your communication. So if a CI is looking for a personality test type of thing to send to a student, it's a pretty professional one that really is geared towards the communication and leadership aspect of a clinical setting. And I'll get the link for that right now. Thanks, Kara.
Does anybody else have a question?
Yeah, I had a question more for the CIs, and then students can kind of jump on this. How are you kind of breaking down sessions in terms of either reflecting on them in terms of and what went well, what didn't go well, things like that? I'm just going to give an example from my most recent clinical. I was in an acute care floor. After every single session, my CI didn't give me any feedback at that point. She said, give me your reflection. So I went through step by step what I think I did well, what I didn't do well. If I did this session over again, well, what would I do differently? So what kind of tactics or strategies are CIs doing with their students?
I try to break it down after each scenario, especially if we're in the ICU areas and we're seeing very different complexities of cases. What didn't go well, and I try to focus on a strength in the room that the student did really well.
I'll jump in a little bit on that. I'm a CI in acute care, and I know it was mentioned earlier that acute care isn't necessarily as focused on in the academic world. So actually, rather than asking a student, what would you do better or what would you differently, because they may not necessarily know what better would be or what different would be, I guided a little bit more under, I'm curious why you chose this action. Can you tell me a little bit more about that? So rather than throw it out as that broad, foggy, well, did I do something wrong? Did I not do something wrong? It's a little bit easier, I find, for the students to kind of be guided in, this was an interesting choice. Why did we choose that? So that way I can see what the actual thinking was versus what the actual behavior or outcome that way. So I find that actually if I guide them a little bit more with that, we can get usually better objective answers that way from the students' perspectives.
Yeah, it's a great point. It goes back to, critical thinking and why we're doing the things that we're doing. That's a great point.
Yeah, Darren, from a student perspective, with that clinical reasoning, I actually got some feedback from my CI recently that he likes to hear my clinical reasoning. And what I do when I'm working with a patient is I'll just speak out loud and I'll say, I'm doing this glide because I noticed that she has joint hypomobility here and that will increase this range of motion. And it's kind of that practical or competency mode, however you want to call it. But I would do that in our competencies with hands-on practice. And so I translated that to the clinic, and my CI really liked that because he could see what, instead of getting from A to F, he could see A, B, C, D, E, F, with my thinking. And so I would definitely encourage students to do that when you're getting into clinical practice.
Carly, how do you find your patients react when you're kind of narrating the things and why you're doing them kind of in their presence?
Yeah, that's a great question. So I actually tell the patients that I'm going to do it. I'm in an outpatient ortho setting. And what I do is I say, hi, I'm actually a student and I'm going to work through things. So I'll be speaking out loud and please let me know if you have any questions. And usually when I'm doing it, I say, well, there's joint hypomobility here. And I found that this actually really helps my communication because then I look at the patient and I say, what that means is, and I'll explain it in a patient-friendly language. So it's not only expressing my clinical reasoning, but it's also telling, getting that communication that we all talked about is lacking. It's really providing some growth in that aspect.
Yeah, I think that's a great point. I think maybe taking that even a step further, even just trying to talk to the patient, just pretend the CI is not there and just jump right into the lay terms. Because I think once we're all into practice, we're not going to be talking about, hypermobility and other terms. So just kind of throw in just the lay terms and actually talking to the patient could be the next step above that. It's a great idea.
And I've even had patients say, I really like that you told me why we're doing this. I feel like I understand everything so much better now. And it made me feel good because they were so excited. But I want to touch on one thing that Andrea makes me do at the end of each week as we have our weekly reviews. But she says, focus on one person in particular that you thought you did really well or you struggled with, and kind of walk yourself through that and say what you did well so we can build on that or what you think needed to change. And so instead of thinking about everything, I thought about that one person that I worked with, that one patient, and it really helped me break it down to see where I needed to improve on some certain things and what I was doing well to repeat with my other patients.
So Heather had a really good question in the chat. She said that, have you guys had any pushback on that? I'm assuming she means from the patient. Speaking in lay terms is so much less intimidating to the patient, but I want to make sure I look qualified.
Yeah, I think that's a really great question, but I think that even shows that you were more qualified to be able to take something that's so scientific and so physiological and put that into lay terms really shows the qualification that you're able to communicate to a patient something so complicated into a language that a patient can understand. So that's just my opinion.
And I've found that patients want to believe you're qualified, even if you don't feel necessarily that you are. So you've kind of have that working for you, wherein, you are this provider. So they're going to be hanging on your words regardless of if they're right or not. And so that's kind of, you can kind of keep that in your mind there, is that, when you're talking to them, you're going to be qualified in their mind simply by the fact that you are, giving them this therapy that they otherwise wouldn't be getting. I think I don't want to say all patients know that. Obviously, you might run into a patient who's been a nurse for however many years, or is secretly a physical therapist and elects not to tell you. But I wouldn't get hung up on trying to make yourself look qualified to your patients, because most of them will just assume the best of you.
If I could jump in too, the other part too is that you have to make sure that your patient understands you. So with all of the things that you're learning in school, you could run a dissertation in Greek or in Latin with everything, and it's not going to help you treat the patient if the patient really can't even understand what they're trying to even do for themselves. So it's okay to throw out, anatomical terms or things of that nature. I work, like I said, acute, but I work acute neuro, and there's lots of Greek and lots of Latin terms that get thrown around. But if I start naming off, oh, this part of the brain and this part of the brain, that's okay. But I'll also break that down of, okay, so it looks like, the doctor said that there was a stroke in your basal ganglia. That part of your brain actually helps with this, that, and the other. So you almost act as a translator, and that actually really helps breach that communication gap, because a lot of the times with, like I said, especially in acute care, doctors don't have the luxury of time that we do with our patients. So they'll zip in and out and say, oh yes, you have a stroke in the pons, and the patient or the family might be like, what is the pons? And so you actually act as a translator for some of those things. So it's actually not a bad thing that you can break that down for your patients. They're actually going to really, really appreciate that.
Going off of some things that Chase said, I think it's important that the students tell them, hey, I'm a student. And then if my patients ever have that kind of deer in headlights look of, oh no, I'm right there. So the student's like, but here's my CI, and she's, here to observe to make sure, X, Y, and Z is going to happen. But the patients have all been really receptive to working with any of my students, and they like the student perspective on things, and they like hearing what's going on in the process and what's going to happen, and we're going to do this now, and then we're going to do this next. And they seem to be very open to hearing it step by step.
So I've got a question for other CIs. With everything that's been going on in the past year, we kind of expect a couple of delays in some skill sets and communication, but have you guys actually been surprised with any skills that students are bringing in that they might have acquired over the past year from virtual learning? And then students as well. So have you felt like you've gained any experience or skills that you might not would have in a regular class setting?
As a student, I'd say definitely flexibility and ability to adapt. I think that's been pretty obvious for a lot of different fields through the pandemic, but just to be able to build on that, I think is important, to being able to apply that to the clinic as well, because things are obviously not always going to go how you want them to, or you're going to have to change plans last minute. And so just being aware of that and knowing that you've already gone through that for a year, I think is a helpful mindset going into clinicals.
I was so excited to actually be around people and work with people. I was so energized the first day and so excited to be out there, that keeping that energy up and keep on staying excited, that really helped me push through all this. It really helped me prepare. So it's good to be excited. It's good to be I was a little nervous, but tap into that excitement and that passion again. And it really helped me push forward and made me want to learn again. So don't be afraid to tap into your roots of why you started doing this to become a PT.
Chase, you actually asked a great question in the chat. Something that I've experienced with my students, and then even as a student myself, my last rotation, I was introduced as a doctoral candidate to patients by my CI. It'd be like, hi, this is Kenny Wessel, a doctoral candidate from Mercer University. He's about to graduate. And then they understand, oh, this person's got their doctorate. And so it might be a little bit different for Heather, but I think explaining and almost saying like, hey, they're educated, they're here to practice their skill sets. That's been really helpful. And I've never had a patient push back when either I've introduced students like that or I've been introduced like that.
Yeah, I've been, for my one clinical, I was introduced as a doctoral intern, and another one I was introduced just as a student. And I found that when they used to say doctoral intern, that I received more respect. I felt I was more respected than the term student. Obviously, I wasn't in a place to say anything about being, a student in the other clinical, but I didn't feel I had as much respect, unfortunately.
I've been introducing as a clinical intern or a student on my rotations, and a lot of people have been fine with it, but I did have one patient when I was doing an evaluation give a little kickback, and she basically said I'd prefer to be seen by a practicing clinician, and I said I completely understand that, and I brought my CI over, and she said, I understand that, I'll sit in. I was going to be there anyway, but I'd love if you'd allow my student to have the opportunity because she's qualified to do this. And having her back me during it was really helpful. And she just sat right next to me. And I would, again, speak out loud, and it really helped. And the woman actually really was fine with me being her evaluator at the time. So, and I saw her again today, and she was really excited to be there today and with me. So.
Kind of branching off what Carly was just talking about, I'm just curious if any students or CIs have noticed a difference in patients with COVID and how they react to having students treat them. They probably don't know how the education's been affected, but I'm just curious if that has been any different.
I had someone ask me point blank if I was ever in the classroom. She said she was very kind. She didn't even question me treating her, but she was like, so did you have an entirely online education? Did you even do stuff in person? And I said, we did a couple of months online, but we actually were able to complete all of our labs. And we just did them all in a compressed amount of time at the end. So we just restructured our program and still were able to get the same number of clinical hours in. And having something like that prepared for if someone were to ask you is really helpful when you go into clinic. So that was something that my program did a really good job of, is in telling us, you got the same number of hours in lab. It felt different and it was structured different, but you still had the same hours. So you can tell patients that and not be lying. And if that isn't the case, you can say, I only had a 3-hour reduced lab. You know what I mean? Like, you can find that where you can express what you actually have learned in class. And I think just emphasizing that you're still getting knowledge. And like you said, Kara, that we have actually learned to adapt so much better. That's been brought to my attention many times. I mean, if you do an exercise and it's not working for a patient, you have to be able to change like that. So we've really, our generation has gotten good at that.
So for the CIs and students, I'm going to throw this one to Dr. Maynard first. What are you doing to help prepare for clinic and bringing in a new student this year? And how is it different compared to the past?
I would say preparing for the students' arrival has been a little bit more difficult with just like I said before, the schools have had to have so many different shifts from one week to the next, and we give all of our commitments a year in advance. So our 2022 commitments are already finished. And so when the schools were asking for a shift here and a shift there by even a week, it made the world of difference to me, where I was having 3 or 4 students in the clinic at one time that were all assigned to me, and that was not doable. So I asked for help, and I recruited some staff members that I felt were very competent that could help me guide these students along in the beginning until they could come back to what was originally planned, but just giving some flexibility and letting the student know that up front first. So we didn't have to cancel on a school and cancel on a whole site just for, a 1 week overlap or a 1 week issue. But our, CIs at our facility have been great with just embracing the students and helping them learning along their acute care journey and helping them with their skill sets and just letting them practice and letting them get their hands on the patients and giving them feedback on what needs to be improved upon. But in the beginning, I really think just communication, open, honest communication about what you're stepping into helps ease the students in, but that's been a lot of preparation work that had to be done ahead of time.
Are there any students that have had a rotation during COVID and then pre-COVID? Darren, I might even recruit you for that. Did that ever happen?
No, I was summer last year, so I was still COVID, and then I went virtual for just finish up electives, and I did 2 more rotations. So no, unfortunately not.
We had a short-term rotation the semester that COVID happened, so I went to clinic twice, and then I had to not go to clinic, and then I got to go to clinic again later. But what kind of question specifically do you have regarding that, Kenny? Sorry if you could repeat it.
Just how you would prepare differently during COVID and then how it differs from either beforehand and as we're kind of coming out of this, how it's going to differ for the future.
Yeah, so in terms of clinic beforehand, I just kind of prepared for the patients that I was going to see and kind of what I might address in clinic. But when it comes to COVID, especially right now, you have to prepare how to tell someone to wear a mask in a clinical setting. I don't know if anyone has had to deal with that, but every single patient walks into our clinic without a mask on, even though there's a massive sign. And then every single patient says, but I'm vaccinated, and the CDC says, and then we have to say it's company policy. And also the CDC has an exception in healthcare facilities. So just kind of that sort of preparation. Again, communication is really huge here. Knowing especially since it's a political discussion now, knowing how to keep those boundaries between patients. You don't want to be talking politics in your treatment session necessarily. So I think that it's been really good to practice that sort of thing. We had a difficult conversation assignment. We had a couple of them in class, and having that sort of thing, preparing yourself to have a difficult conversation with someone is really great. And so even with your friends, you could have someone pretend to be a patient who is struggling with COVID precautions and keeping them. Maybe you could have something like that and have them be a little inflamed. That would be something that I had to deal with this past week. So definitely at this point in time, I think communication is really a big part of it. And I think also another thing is communication with a mask to and from a patient, especially patients who are hard of hearing. So I've had a couple of patients who really have a hard time understanding what you're saying. And I've noticed that so many people are so quick to just nod their head and pretend they've heard you, even if they haven't. So really catching those context clues and those nonverbals that you can hardly even see because they have a mask on. So also nonverbal communication.
I agree. So many patients are lip readers, even though they won't admit to it. But our patients that are hard of hearing really do focus on looking at your face and what you're saying and reading your lips. And all of that is kind of gone right now. And then some of us, we're wearing goggles and even a full face covering when we're going in some of the rooms, and it's even more difficult there to have any interaction or connection with the patient. So definitely from here up, even if you just have these facial expressions, it really matters. They can be picked up on very quickly.
I think this kind of leads into the point too that it's not equitable across practice settings. I'm currently in a inpatient rehab facility, dealing mostly with patients who have had strokes of various kinds, and a lot of what we do in that setting is preparing patients to go from their acute care stay to either their home or skilled nursing. But the fact that it's such a big hospital, and to get down to the therapy gym, we're limited still in the number of patients and providers that we can have in that gym. And so kind of looking at the schedule for the day, and I don't know if this is a struggle that anybody else is running into, but like if there are a lot of people that are already in the gym, you might have to kind of turn your patient around, go back and figure out how you're going to treat them in their room, which can be a challenge. It's if you don't have those same things that you're used to working with in a therapy gym, still making that skilled therapy session for them so that they're continuing to make progress. I know this is a little bit more specific to this setting, but for those of you who are going to go to inpatient rehab, and it might happen while we still have a little bit tighter restrictions, it's just something that you wouldn't necessarily think about having to plan on top of trying to fill an entire hour's treatment session. I think another big part of that too is remembering that our patients are people, and especially in this setting where they're maybe in the hospital for a week or so, and then they're inpatient rehab for a couple weeks before they're safe to go on to that next level of care. Some of the things that we take for granted, such as like going outside, they don't, whatever your kind of hospital's protocols are, seeing if you can figure out ways to make those patients feel more like people is a little bit difficult. Like if you want to take a trip outside just to get them some air that's not inside the hospital, you kind of have to prepare for the entire COVID aspect of that, and not just from kind of a medical, if they're medically stable to go outside. So it's been something that I've had to learn for this setting specifically, but something that I never anticipated.
Chase, I appreciate that comment about the making adaptations if you can't go to the gym because the gym's already full with other patients. We had a patient the other day where Trevor found out that the patient's goal was to be able to go home and help his sister wash the dishes. And so he had the patient stand at the windowsill, and he was reaching for different shaped objects while standing inside his walker, and then handing them to one side, and then reaching for a different shaped object and handing it to the other side where I was standing, and just working on something that closely simulated something without being at a sink and having soap and water, but doing something that was meaningful to the patient, and then telling the patient, that's why we're doing this. We're going to try to simulate this.
So I have another question. It's kind of a challenging one, and it might take a little reflection to think about it, / if you think about it right now and you have a response, that'd be great. So I think a lot of times as students, we don't know what we don't know. And especially students who are in the COVID time, we don't know what we missed because we didn't have that experience that other people had. So students, how can you find out what you don't know and seek more information? And CIs, how can you assist students in realizing what they don't know and realizing their gaps that they might have?
I think it's important for CIs to recognize that imposter syndrome is an actual thing and we never lose it. And so being open and honest with your students. I mean, like as CEIs, we learn having students as well. And so being open and honest of saying like, hey, I don't know everything either. But then if there is that open communication, which I feel like is the overarching theme today, there is that ability to kind of feed off of each other, and the student will feel comfortable of like, okay, well, they don't know everything. Then it's okay for me to say, hey, I'm not really sure about this. Can you teach me more?
I liked hearing about stories of before COVID and how things changed, because I had no clue. As I said, I was a student the whole time. I don't know what the difference is. So Andrea would tell me stories of how things used to be done and how that's changed. And that surprised me in a lot of things. So just having that communication. And I also had a chance to talk to a couple students that just graduated, and they're like, wow, I can't believe you're going through this, that we had this, this, and this. And it was interesting. And the question is, will we go back to that? I don't know. Is this the new norm? I don't know, but it's good to be prepared in case it doesn't go back, or in case it does go back.
I know one of the things that's changed from the professional to the student perspective, I also help guest lecture over at our local university here in Texas. And one of the things I help with in some of the neuro courses is I would bring former patients in for stroke and spinal cord. And literally the tactile hands-on learning that is so important, especially in lab. Like you said, you have the same amount of lab hours, but you may not necessarily have the same tactile learning that you do to actually feel what spasticity is, or to actually feel when the weight shifts, and for proper handling of patients. And I know practicing on a normal body is very different than practicing on a patient that carries impairments with them. So when I have my students now, because we're getting ready for a new batch, and I'm really looking forward to them, I will certainly take an extra day or so at the very beginning. And then if we have any patients who are especially challenging, so if we have any pusher patients, if we have anybody with some gross motor deficits like that, to actually take extra time with the handling technique, because that is something that I know was missed in some of the coursework, that students do not necessarily have all of the experiences that we in the clinic wish that you guys did have coming in, to make you guys feel more comfortable with it. So I think the CIs recognizing that the handling knowledge may not be there, and likewise for the students, like you said, the imposter syndrome of like, oh, I don't know if I really know what I know. You don't, and it's very important, again, to make sure that's communicated of, I'm not sure if that felt that way, or can we try that again, or what else can I do? So I think some of that tactile learning is very, very important, and taking some extra time in your clinical experiences to ask for that if you feel that you need it is something that's worthwhile.
All right. Well, I think this is a good time to wrap up. I think we only have a minute or so left. So I just want to say thank you to Trevor and Dr. Maynard, and then Darren, Carly, Kara, for everything you guys have done. And thank you guys for being just engaging and such a great group. Thank you guys so much. And I hope you guys have a good night.
Good evening, everybody. So I see we've got faculty. Looks like mostly faculty. Excellent. So what I thought we'd start with in our little breakout room here is, again, this is going to be faculty and site coordinators of clinical education, but I thought it'd be nice to have just a brief introduction of everybody. Tell us where you're from and what your role is, if it is strictly faculty or if it is actually clinical education faculty. I know this is always fun on the Zoom roulette, so we'll start. I'll just go by name. Is it Marissa?
Yes, it's Marissa. So my name is Marissa Berkmeyer, and I'm the DCE at George Washington University in Washington, DC.
Excellent. Thank you, Marissa. Lisa.
Apologies, I'm learning how to use multiple screens.
I'm Lisa Hayes. I am the DCE at UCSF SFSU PT graduate program in San Francisco.
That's excellent. And that's part of what we're going to be discussing in here is learning how to use virtual screens, multiple screens, all the fun we've had on the faculty end. So that's good. Janice.
Hi, good evening. I'm Janice Howman. I am the Director of Clinical Education at Ohio University here in Athens, Ohio. Thanks for sponsoring this.
Absolutely. Thanks for coming. Vanessa.
Hey, good evening. I am Vanessa Everett. I'm the DCE at Augusta University here in Augusta, Georgia. Thanks for having me.
Good to see you, Vanessa, one of my partners in crime here in the state of Georgia. So, and Sharon. Sharon, I think you're muted currently.
All right, sorry. I was in transit, I just got home. So, hi, Lisa. I'm Sharon. I am the site coordinator of clinical education at UCSF Medical Center.
Excellent. Thank you so much for being on. And then I realize, Carrie, you haven't had a chance to introduce yourself yet. So if you want to go ahead.
Okay, I'm Carrie Hawkins. I'm the director, or I'm a recovering director of ClinEd. I am currently a program chair for a developing program at Whitworth University. And I still think that the DCE position is one of the hardest out of all of the faculty, so.
And she left me at the beginning of the pandemic, so.
It was totally planned.
Still love you.
So thank you all again for coming on. And what we wanted to do is just provide an opportunity. We have Kristin here as a site coordinator. We have all of us as DCEs and faculty. We want to provide an opportunity for us to really share what we found to be best practice. And we really want to hear more from you. You've heard from our panelists already. We want to hear from you and each of your individual universities on things that you've been doing that have really helped promote and help their students thrive as they head off into clinic. So we want to open the floor. I think since it's a small group of us, I'm okay with people just unmuting as long as everyone's okay with that and we're respectful of each other offering our opinions, but feel free to unmute and jump in. How do our students thrive?
I'll just jump in and say, I love that Carrie's a recovering DCE because I'm a brand new DCE. I just started in April. So our recovering DCE actually just jumped off to prepare for the CAPTI meeting that she has in 30 minutes. So she's the recovering DCE and I am the brand new shiny one. So I'm going to share that phrase with her because I think she's going to love it.
I think that people underestimate, they just think that any clinician can do that role, and it requires a lot of organization, networking. There are certain skills that go along with being a DCE, but I think that that's why this is like a time for a DCE to shine during all of this, because they are willing to reach out there and coordinate, and they know their clinicians at all of the sites, like they are in contact with everybody. And so I think that the role of the DCE right now is so important and so valuable for how we're getting our students into that entry level abilities, because our students are the future of our profession. I know I put that in the chat earlier, but without DCEs, we would not be moving forward like we are. So it's a very valuable position.
Yeah, I was just gonna say, for this past year, so for us, we just graduated our cohort that did their whole clinical year through all of this. And then now I've got a group that's gonna go out into clinic for their full times and then go do their kind of clinical year starting in June. They're both very different groups. And so that's kind of where I'm struggling a bit because the group that just graduated, they went into clinic in the very midst of the pandemic and had experienced all of their clinical placements, the vast majority of them all getting canceled or restructured or whatever. So I saw the adaptability with those folks. with the group that's going out to clinic now, it's more challenging. I'm seeing it's more challenging for them. And I truly don't think it's at any fault of their own. It's just the circumstances of, you know, they didn't choose to be in a program that was hybrid. They didn't choose to, you know, maybe they knew themselves well enough of like, that's probably not going to be a good program, but they were put in a position that they were going to. So I just did an orientation with them. And I tried to focus a lot on like growth mindset and, you know, and all those pieces, but I still feel like it fell kind of flat and, you know, and didn't really take it to where I was hoping. And so I guess I'm just getting more anxious as we get closer to them going out to clinic, you know, of how, you know, we've done various things. We're going to do our skills lab coming up if we do one of those as well. But it's, yeah, I'm just a bit struck. So that's one thing I wanted to say. The other thing that I wanted to say too is I do think we're a great group, DCEs and Clin Ed, clinical faculty, because we made it through this year because we've been very adaptable. I'm really hoping that the professional will take that forward, because I think if anything I learned too is the group that we had to cut off their final 4 weeks last year to get them graduating, and you know, they are fine. They've been practicing for a year. They all passed their boards. They're all doing fine. What does that say for how long Clin Ed needs to be? You know, and so that's something that I'm really hoping that will kind of move forward in PT education, of really looking at, you know, what is the need to have and what is the nice to have. And so I'm hoping that kind of will stick. And I think from a Clin Ed perspective, we really demonstrated that in a concrete manner of how we've still been able to produce competent clinicians who are able to practice and are ready to practice.
Those are outstanding points. I think just for me to add to this, and of course, you know, I said it a little earlier in the call, our job was made infinitely easier by outstanding site coordinators like Kristin, and all of us have those site coordinators in their back pocket, right, that you can call on. And that's, you know, not only site coordinators managing all the cancellations, but often managing things outside of their control, like policy above their head that said what you can or can't do and when you can do it, or not even knowing when you could do it, kind of that unknown. I think it speaks to, again, how I think each of us have strengthened that bond with those site coordinators and those CIs that have already been rock stars and are now just even closer in regards to that clinical education circle. So
I was just going to reiterate basically what you said before about having 2 different types of students, with the ones that were going through their clinical rotations in the midst of the pandemic, as well as the ones that we're seeing in the now. Their learning style is different, and obviously in person, virtual, but at the same time, CI, I'm trying to teach them what it's like to be a PT, and I'm learning the different ways through the pandemic, what it's, you know, made me have to change and modify. So I'm learning too at the same time. I've leaned on Carrie, I've leaned on Beth, to say, hey, be patient with me. We're trying to get us, you know, ready for you, but at the same time, I still have to make sure my staff, my patients are taken care of. So just give me some time. And they've been great. They've been very flexible. They've been very understanding with everything we've gone through. I think some sites, mine included, with being at skilled nursing, have been a black hole in the whole COVID-19 pandemic. So with their flexibility, with understanding what we can and cannot do, and all the policy changes, it's just been a lot easier for us to do what we're good at, teach.
Yeah, I was going to comment on the on those different cohorts, the students that their Clin Ed course was most disrupted by the pandemic, but they made it through. We now have students that started normally in the classroom, but ended very atypically, and on some of their advanced level courses, which can be concerning to know how well they learned the material. And then our cohort that started online, which just still blows my mind that they had a full semester that summer online. So it is, I do have some anxiety as a DCE on how they're going to progress through the clinicals. And to comment to Marissa, I think students and faculty and clinical faculty are also reaching a different level of fatigue too, though. I think everyone like dug deep and rallied so hard. I mean, I got more placements than I ever thought I would this past year. Like, we kept students with their full, like for the most part, their full normal experiences, when I was prepared to slash everything in half, and, you know, because they were so generous and so willing to help out in this crisis. And now it's like the crisis keeps lingering. And I think this next year is going to be very interesting, though, on, okay, how can we sustain this, this level of, you know, professional give. And so that piece is going to be interesting. I just feel like we're starting to feel it from all parties involved, students, faculty, and clinical faculty. So it's going to be interesting this next year. So
I can say that because as a new DCE, I'm coming in and we have 4 different rounds of clinicals happening. One finished, one is just ending, one is finished and needs to be graded, one is ending this week, one started at the beginning of the month, and then the ones that we're grading are now going out for their like makeup from last year clinical. So this is like me learning in the pandemic, and I'm like, oh wow. And everybody, each cohort has different rules. And I wish I could show you guys my wall. Vicky is a faculty member at UCSF SFSU, and she just joined the room, but like my wall is covered in sticky notes for all the different rules for each different group. But I wrote it in the chat. Like, I think it's also a testament to the adaptability of these students that every single cohort is succeeding. And like you said, what does that mean for us moving forward?
I was gonna add, oh, sorry.
Go ahead.
Oh, sorry, I wasn't sure who I stepped on. In kind of thinking about that, I do think that our students have been resilient. I mean, I think the communication, the collaboration with our clinical partners, and then also with our students, I mean, that has been so key, is to maintain that strong partnership with all the stakeholders in clinical education. And that's what's helped us get through and to maintain this level of success. But I still wonder, is it the level that we need to be at that truly is entry level in contemporary practice? Because while I know many of our, all of our students graduated, they all got jobs, they all passed boards, they, what is our measure of success? Because I've also talked to some of our clinical sites that have hired them and have worked with them, and they said, we expected them to not come in, we gave that leeway that someone we were talking about earlier, is that we knew I had to mentor them a little bit more. They weren't quite hitting the ground running, but they had the basics, and we knew we could get them where they were going to go. So it wasn't a bad thing, but again, to that pandemic fatigue that Beth was referring to, is that forgiveness, is that leeway going to be, or do we need to get them back up to snuff? So again, I think Marissa's suggestion, we need to develop some sort of study in terms of this length of clinical, and maybe we can cut back a little, but we have to be careful how much, and where is that sweet spot? I wish we could figure that out. So Marissa, if you figure out how to develop that study, I'll join you.
Yeah, so I'm Sharon. I'm the site coordinator at UCSF Medical Center. And I think that this past year, both the students and the DC and the clinic site and the CIs were just all extraordinary. So when we, when the lockdown started last March, we had some students who were in the middle of their clinical, and we were told that they have to finish by this week. Literally, like, we have half a week to finish them off. So we had some students that were kind of toward like little past halfway through, and we had to wrap it up within a week. And fortunately, we felt that they had learned enough skills to be able to kind of pass that clinical. So, I mean, we cut it short like 3 weeks and we just passed them. So we initially had to, so the same question what you just asked Janice, is like, you know, what is the right length? You know, I mean, do we need 12 weeks? Can we, you know, go by a little less? And then the other thing was that we did have to actually cancel the clinicals that was supposed to start right when the lockdown happened, because that was told by the administration. So, and that really broke my heart, because I know that some of these slots are really difficult to come by, and you know, there was a lot of work putting this in place, you know, both for myself, coordinating with our CIs and our staff, and coordinating with the DCEs. So, you know, I sometimes, like, I wanted to cry actually, because some of this placements, like in the pediatric setting, was something that we've been working on for over 2 years. But anyway, another thing that we also did actually was when we opened up again around July, when we were able to open up, we actually started taking students 2-to-1. So yes, so we actually took, at the end of the year, we were able to accommodate as many number of students as we did in a typical year, because all the ones when we opened up starting from June, we did 2-to-1 model, and going forward we're doing 2-to-1. And Vicky, who just joined, she's actually a faculty at UCSF SFSU PT program, and also works at UCSF Medical Center. So she actually was kind of voluntold. She was the first person to kind of she got voluntold to do the 2-to-1, and then after that, rest of the follow-up CIs, we did the rest as 2-to-1 model. Yeah. So, and the students did, you know, most challenging thing was space issue, to be honest, because of the social distancing rules. Every other workstation computer was closed off, and for, you know, 2-to-1 model to have like 3 people, the CI and 2 students in one area, to have access to computer in our department, and also like on the floors where the patients are, that was a big challenge, the space. Yeah, but we got through it, and we're still going through it, getting through it.
Yeah, that's great, Sharon. And I think it's wonderful that you discovered that the 2-to-1 is working for you and kind of moving forward. One of our close clinical partners had to stop doing 2-to-1 because of the social distancing. So we're hoping that will go up. But I know that a challenge that I had, and has been just as with many, every DCE, is just the inpatient and getting that. And I think that, and that's actually something that I am interested in probably looking at, you know, what is it, maybe not the full length, like maybe the minimum 30 weeks, you know, maybe that is the number, but what does that comprise of, you know? And I think that's what also we've kind of touched the surface on, of our students meeting the expected competencies if our curriculum is sane across the continuum of care, across the lifespan, but how many full-time weeks is required in each of those, you know? And so it's not defined. And so that is something that I played with this past year. And, you know, and I think it was successful, and it's still, you know, ebbing and flowing. But prior to pandemic, we would have students all the time who would do split rotations. Half of it would be inpatient, half of it would be outpatient, or maybe 2 days a week it would be inpatient. You know, why can't that be more regular? Because that's going to expand the type of experience a student would have. And I did have to do some creative, you know, replacing like maybe 2 intensive weeks in acute care, tacked onto another one. But it actually, you know, the students like, no, it was good. I would have liked to have more time. You know, that's in the C. I would have liked to have more time, but we really tried to nail down what were the competencies, what were the expectations. It was when we did not use the CPI, you know, like what was it that was expected in that 2-week period. And so I think when there's an expectation of what the end goal is, and it does oftentimes need to be specific to the setting, that might help kind of frame well, how many weeks is that? And I guess that goes like kind of a whole nother conversation of competency-based education, you know, of where is that and can there be a little bit more flexibility there?
Because that almost leads it into, could it be a time variable competency?
Right.
Where some students are able to finish in 8 weeks and others need a full 10. But then, you know, it's almost like a Pandora's box. How do you get clinical sites on board? Because they don't know when, you know, when the student's going to finish. Clinical instructors need to take vacations. Clinical sites need to be able to be ready for that next student. You know, there's just so many factors that go into it. And at what point do you say, okay, I'm going to start the next student a little bit later because, you know, I've still got this one student, or can I do the 2-to-1? I used to get students, the first student to orient the second one, because I would do a 2-to-1, but I would overlap them so they staggered start and stop times, which helped with the CPI and the onboarding and everything. And so I love, Sharon, that you and Vicky are doing 2-to-1. Kristin also, they do a 2-to-1. Andrea does a 2-to-1. And it's almost like we need to get everybody together to see what are some of the best methods, since there's so many different ways to do that. But figuring out how we could do that competency based, that so some people can finish earlier, or some people can have that extra time without paying extra tuition, you know, things like that.
Or if they could finish and have a few weeks in a really high specialty clinic, you know, like maybe, you know, because there's obviously the money issue and tuition that factors into that too, that universities probably wouldn't like it if their students are skipping a semester, but that could be the result. But it would potentially provide an opportunity for a kind of a specialized clinical type of experience.
So to play devil's advocate, because Vicky had the voluntold 2-to-1 model, and Vicky, you can chime in, but there was a lot of pressure to get them out, like as soon as they hit entry level. But then the question was for one of those students who was very passionate about acute care, he was unable to go into the critical care unit, which had he stayed for the additional 2 weeks, which was the extended time, which was the standard time, he would have had that experience. And so, you know, as a devil's advocate, like, are we hitting entry level? And are we giving our students all the experiences that they should have to be a well-rounded therapist? You know, so just playing devil's advocate, because I was the backup CI for Vicky for those two.
Yeah.
So
yeah, and that was interesting to be in the middle of that, because it was, and Sharon too, just allowing, I mean, it was great that we had this flexibility, because there was a pushback and start for a couple of weeks that they had the flexibility to say that if they're hitting entry level, there's still enough weeks, you know, to hit, you know, minimum CAPTE guidelines, that they can leave at 10 versus 12, which helped with those that just needed the inpatient portion to get in, hit entry level, and get out and move towards the boards. But yeah, it did kind of penalize those that did want to kind of explore around a little bit more, and there was some I don't want to say complaint, that's not the right word, kind of some protest on his part that I have essentially paid tuition for this, and I'm basically getting cut out because you know, sites are concerned about the pandemic and what that means public health wise, to have more people in this space. So like you said, Lisa, there's kind of two sides to it.
And it's a struggle too, because sometimes you're like, okay, great, we're shooting for minimum level competency, or like, what is the you know, the lowest bar. Sometimes almost it's hard. We have at our program, we are very heavy on Clin Ed, and it needs to be trimmed down. And I think this past year's helped with that. But it's also, you know, and some students need that full 12 weeks, but it's also nice for some students to they can be a rock star by the end of this rotation. And to, they also may have that extra opportunity. It's just figuring out where that target is that you're trying to shoot for on entry level practice. That's so challenging. So it's also hard to call a CI and say, hey, I think this one's going to need a full 12 weeks. So do you want to take them, please? Thanks.
I was just going to speak to that. Being a newer DC myself since January, it's been, I guess, not a change, but I felt the need to be so much more transparent than ever before, both with students, but like you just said, Beth, with CIs, and just being upfront and honest and trusting them to trust me, that this is the best placement for them. And I think that's one thing, like when we started out saying, what have you done to help students succeed, but also help support the CIs and SCCEs, and it's be transparent, as possible, with every expectation that we have. And then being honest and saying, hey, we think this student might need some extra help here. Are you willing to step up to the plate? And I think those conversations happen so much more during COVID, during the pandemic than maybe they did before. But I think that's something that we've learned we should continue on with. And it's been pretty valuable, reestablishing that trust and just being straight, transparent, especially with our classes. Like you said, the different cultures and the different batches of students, they've appreciated the transparency of, here's what's going on, here's what CAPD expects, here's what we need out of you guys. And they've seemed to really respond well to that, rather than playing the politics, a little bit with them. So I think that's reached them the best that we can, but I'm still learning. So any feedback would be helpful. So
You've done outstanding, Vanessa. You've been off to a great start. I think it's so key what you said, that transparency. So I don't know about y'all, but even the CIs and the site coordinators that we're so familiar with, we get ready for a clinical rotation and we send them the canned email. Here's the syllabus. Here's everything you need. Students coming. Thanks. You guys are great. This year was a chance to reconnect with them and really sit down and say, okay, you've been awesome for us. We know each other like a book, but let's really talk about what's happened this year. What's going on with our program? What of our students, what's going to be different about our students? What are we concerned about? What are the things that are different? And from a site, what's changed with y'all? What is different from you? And how can we prepare our students? It's allowed us to re-engage even with our really strong sites and CIs to just say, let's make sure we're on the same page here. And it's really allowed us to reinvigorate those relationships that we've had and maybe taken for granted just because they've been so good and always been there. It's allowed us to reconnect that. So I've enjoyed that this year.
So I'm going to share, and Sharon's going to get the inside scoop that we pair with another local university, the other DCE, and we usually do like a Con Ed day for the SCCEs, and it obviously got canceled during COVID. So our plan is to reattempt that at the end of September and give our CIs and our SCCEs exclusive invitation to Zoom, because we can do 350 people on Zoom, which is the silver lining. But we're also going to give them their ethics and jurisprudence CEUs for free. And so, in addition, do some other like Con Ed stuff, which is something that UCSF and Samuel Merritt have often done, but we're expand. It's usually just the SCCE, and we're expanding it to the SCCEs and all the CIs that helped our program throughout the pandemic to kind of like say thank you. And we're asking someone to do a pro bono ethics course, which is required for California. So I don't know if that's a best practice in your guys' area, but I thought I'd share that that's what we're planning for September.
Yeah, so we do that just as far as like an annual give back, a Con Ed, and we come up with something every year, and we had to cancel the one last year. It's funny because we kept rescheduling it, thinking we'd be able to do it. Yeah. So we did it this past spring, and we used Zoom, and because we were able to, this was the first time we were able to invite clinical partners from outside of our drivable distance to campus. And we do have our students going all across the country. I think, and this is just a suggestion for you if you haven't had it all planned yet, we focused actually, because again, I've done 2-to-1, I've done all kinds of clinical topics. But the focus this year was COVID. How did we get through it? What did we learn? So I invited clinical partners, CIs, SCCEs to do a panel discussion. And basically, like, I chose somebody who I knew was doing telehealth with their students, because I thought that would be an interesting topic, and just a variety. And then some of our close partners who were amazing and how they kind of adapted and changed things around. But what I found, because then when folks registered, we allowed them to ask questions like we were able on this one, is that they were asking questions about GW and about what we did. That's what the CIs wanted to know, is how did you change or not change your program? What was it, so it ended up shifting. We still did a good chunk of our time on the panel discussion, but I would suggest also kind of talking about your program. And that's back to that transparency of being really transparent with everybody, because they didn't know, and some of the things that we were doing. And they found a lot of value in it. And they got CEUs out of it. If they were in DC, it'd be automatic in Virginia, but like other jurisdictions, they'd have to. But it was great. And we made sure that we invited, some panelists that were in California and, in New Jersey and different areas. But that I would suggest, to kind of add. And I think that was very well received.
That's awesome, Marissa. I just threw in the chat. That's what we're doing in Georgia, is we're having each DPT PTA program submit, like, what's the top 3 things you want CIs to know about what your students have changed, or what's your concerns? And we're sharing that document. We're going to have each DCE fill it out and really share it with the CIs, the sites. And I don't know how your consortiums run. Georgia, over the past 5 years, we have grown so close, and that was perfect timing. As we came into this, because we've really leaned on each other. I mean, there's emails between the consortium, hey, pulled a student from this site closed, do you have anyone in the area? And we've really supported each other. But that's been helpful from what we've heard from clinical instructors, is they're really interested. They want to know what's been the change, what's been going on. So we've got about 9 minutes left in the breakout room. So I thought what would be cool is, before we close tonight with the discussion, first of all, thank you all for coming on. We've really tried to spin this as a really positive message, how we're all thriving, from students, CI, site coordinators, faculty. So I thought what we'd do is, maybe on a positive note as we end, take 30 seconds for each of us to share, what are we going to take from this call to continue to thrive as we continue to look at being resilient? I know the comment was made, the pandemic just continues and is lingering. How are we going to continue to thrive? So I think, if anyone wants to chime in and give their 30-second elevator speech on what are you going to take from this? How are we going to thrive and continue to be successful?
I can go first. I think that we learned how to connect in different ways. And even though we all want to hug people, we can appreciate and celebrate connecting with people in multiple ways. So, and kind of celebrating that, like we still need to mourn or grieve the lack of physical connection that we didn't have, but what a great opportunity to see how we can connect in a new way.
I've really enjoyed it. I think I'm going to walk away from just feeling supported, not feeling alone, on your little island sometimes when you're wondering how you're going to get through it or if things are going to be okay. So it's great to hear, not to hear that anybody else is struggling, but it's great to hear that we're in similar areas and similar situations all over the US, all over the world. So, and I love earlier, I'm actually going to take away specifically the APTA 8 ways to improve your clinical experience. I love that strive to improve, not prove yourself. And so I'm going to actually take a look at that. I saw it was an article, I think from 2018. So I'm going to take a look at that and say, hey, this has even happened pre-COVID times, and chime in with that on my students. So thank you for that. I really appreciate it.
I think I'm going to put out there, we did it for our cohort that started this week, a brief. I tried to stay away this time from the canned emails that we always use and try to make it just a little more personalized. Here's their objectives. Here's what they're excited about. But for our upcoming clerkship students, I think I'm going to try and send out kind of taking that, what has changed with these students to be sure that they're aware of the fact that these students started online and spent that first semester online. And, I don't know if it might create a little apprehension from some CIs, but hopefully it'll create a little more empathy and maybe partnership on helping see these students through that transition. So that is one thing that we can work on this summer.
Well, I'm excited. I've been out of the Clin Ed realm for the last year, and I'm excited and just have an appreciation for everyone that is still enthusiastically trying to get our students to the finish line and still trying to keep that bar from not being at its lowest setting. I think most people are still wanting our students to graduate with injury level because they might be treating our grandmother or grandfather at some point. So I'm just excited that there are still so many people out there that want to do this to help our profession to be a better, so our future is better for us. So thank you all, each and every one of you.
I was going to say something, and I feel bad because I've forgotten the gentleman's name, the student on the panel. He really reminded me how excited students can be when they're invigorated by others. And so something I did, because, again, our class that just graduated, everything was turned upside down for them. So I sent cards out to them after, and I've never done that. But I think that's something I'm going to continue to do because I think it's important for, and I mean, we still have a lot of students. We don't have like 100 or anything. So it's like 45. It still takes a long time. I did that instead of doing holiday cards. But, I think it's important for them to get some individual, just kind of energizing. It doesn't have to be much, but, I think that's something I'm going to try to continue to do, just to keep them, know that their faculty is thinking about them in an individual capacity versus just an email. But he kind of reminded me and made me see like, oh yeah, like he's like, they're on Zoom, they're excited to be there. Like, instead of just, I'm like, yeah, that's, that does kind of invigorate students and helps them, feel seen.
I know that in having this discussion, it's actually helped me to reflect a lot on a lot of the clinical experiences within this past year, talking about the ways that we've had to shift, really, really unexpectedly and quickly. And I agree with just feeling like all of us were banding together and just sharing ideas because we were all in this together, but also like the creativity of everybody, taking the lack of resources all of a sudden and being able to be creative to come up with how do we still create these meaningful clinical experiences. So it's definitely invigorating me in thinking going forward how to be creative in designing the curriculum to help help our students to be more prepared for the clinic, despite the lack of in-person resources at this time.
I really enjoyed hearing everyone's, how they're kind of giving back to the clinic sites or providing, whether it's a CEU event or just, I really liked that cheat sheet that Daniel talked about in terms of the top 3 things that a program wants the clinic site to know. And obviously we've done that each as an individual, but I thought it was really cool how the Georgia Consortium is pulling that together as a group to say, in aggregate, it's not a shortcoming of any one program or a shortcoming of any one student. Here's just some things that are in this new world that we're living in. These are some things that we've noticed and we want to make sure that everyone's aware of. So I thought all of those things were really cool. And I love that give back. So thanks everyone for sharing.
Hey gang, I just wanted to say thanks for all the support and love as a site coordinator, as well as a CI that we've received over the last year, for having our back and understanding and giving us the time that we've needed to make sure our site was ready for your students. But just thanks for everything that you do for us. We really appreciate it.
I have to say, hearing Marissa talk about cards and then Kristin talking about love, my students blew me away this year. So unbeknownst to us, our philanthropic service group decided this year that their philanthropy, all of their service plans basically got demolished throughout the year. They came to us and they said, well, we raised money. We're buying gift baskets for all of our acute care hospitals that are partners, and we're going to bring them and deliver them to the CIs without letting faculty know at all. And so here they were with these gigantic gift baskets of snacks and coffee gift cards and hand wipes and everything you could think of. And it almost brought me to tears in my office just with the students coming in. It was like, how awesome, talk about resiliency and just the energy they bring to clinic. That came out of nowhere. And our CIs just ate it up. They loved it. And it was like, it was nothing we did. It was all the students. And those are the things I'll take away from this is I think the students have that energy, but also that just love of everything going on. They know what goes into this process, whether they verbalize it all the time to us or not, they know how much work goes into this process. So it's been awesome to see.
Thank you all for joining us.
Absolutely. All right, make sure if you get a chance, our Thrive videos are up on the ACAP YouTube page. If you want to capture a little bit more of all the energy of the speakers, those will be up there, and we really do appreciate all of you joining us tonight. Thank you all for your time.
Thank you.
Good night.